Hello, everybody, and welcome all the participants to the open forum for this 14th webinar of the Asian Collaboration for Trauma. I request all the speakers and the reactors to open their cameras so that we can pin you up and the participants can actually see you all while we are discussing this particular session. George Bernard Shaw said once, now that we have learned to fly in the air like birds and dive in the sea like fish, the only one thing which remains is probably to learn to live on earth like human beings. But unfortunately, terrorism or unnatural, sort of man-made disasters like what we have discussed throughout this webinar are a reality, probably will be a reality for times to come, and no region or no country is immune to such man-made tragedies, a source of tremendous human tragedy, human suffering, but still, we as healthcare workers are called upon in the most difficult of times, and we have seen through these webinars and some of the very enlightening talks by our honorable faculty, how they have, wriggled through these unforeseen circumstances in the times of need. I must once again in this open forum thank all the speakers, Dr. Naes from Norway for telling us about the Norway attacks of July, and then Dr. Chong C. Jack, who dwelled upon the Bali attacks and the lessons learned from there. Dr. Avi Rifkin, and I'm really a fan of Israel and a friend of Israel. We came there to Haifa and also to Jerusalem to learn about mass casualty incidents, something which you all excel in, which is unfortunate, but again, a great training opportunity for all of us who have been there for elucidating on the pathophysiology of blast and missile injuries. There are certain questions from the audience for you, sir. And I personally like the accordion approach of stretching and then coming back and then stretching and coming back so that we can play some sort of a music in the times of need. We also had very eminent speaker, Dr. Tina Garder here, who told us how to prepare or what to do in a disaster situation. And I think the message there was very loud and clear: preparedness, 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 training, drilling, and the most important thing, documentation, and then sitting back together and asking questions about what happened. Well, thank you all the speakers. I must thank all the reactors, Dr. Karunadasa, Dr. Laura, Dr. Burapat, and also Dr. Rizal for reacting to our speakers. Without wasting time, I think I'll come back to some of the pointed questions which were raised by some of the participants. I think first I would like Dr. Avi to respond to this question about the off-label use of Novus 7. I think it's been a controversial product for trauma, at least, and what your experiences are in the long run. Obviously, you showed us one particular case in which it helped, but would you prefer, because the cost at times for Asian countries, for developing countries, is very, very prohibitive. What are your views on use of Novus 7 for uncontrolled hemorrhage, sir?
Listen, our experience really when we are using it. And the main idea is to use it before everything is happened, before the coagulopathy, before the cold body, before all the cascade, because usually what people are doing, because it's expensive and because all the question marks about the medicine, about Novus 7 itself, the main idea is to use it, to keep it in your mind, and to use it in the initial, let's say, steps of the bleeding, not as the ultimate result. It doesn't work.
Right.
The main idea is also that in blunt trauma, we have quite a good experience. In penetrating trauma, In this case, it was really unbelievable. She stopped bleeding. After this one shot, she stopped bleeding. She received only later on one PEC cells and she stopped bleeding. There was, as you remember, and in the next webinar, Ken Beauford was the initiator of penetrating trauma and Novo 7. We didn't participate in this study because it was double blind and because we are great believer of Novo 7. And in our case, because as I mentioned before, we are not a peaceful country, we couldn't offer to give it to somebody that need it, in our view. I couldn't, it was against my ethics, against everything, that once we receive a soldier, we will not give him Novo 7 if we think he deserves it. So we as a hospital and ourselves, we didn't participate in this study. The study failed. Unfortunately, the study failed. And since then, Novo 7 was, put aside by the company. I wrote them a lot of letters because I thought we can use Novo 7. We have to do it properly. And now with the epsilon aminocoporic acid, that also, there are a lot of studies, there are a lot of publications. The main idea, it's inexpensive, $10 or something a day, so everybody gives it. And kesara sara. I want to tell you that if you are giving Novo 7 in the time, not as a last resort, it works. We saved the life of Israeli highly prized mathematician that was involved in a severe trauma, blunt trauma, road accidents, and he bled also. He was in a swimming pool of blood, and we gave him a couple of shots, and he stopped bleeding. So you have to know when to choose it and how to use it, not as a last result.
Right. I think the message is loud and clear from your side, Dr. Avi. Yes, we had a couple of anecdotal cases, again, to quote from the Apex Trauma Center in India. But again, as you rightly said, we need to know when to give, not as a last resort, but probably as one of the initial, sort of hemostatic agents. Any other Asian reactor who has had, sort of Dr. Rizal, any experience with Novo 7?
We used Novo 7 before, just like Dr. Avi did. But the problem is sometimes the pharmacological regulators at that time had spoken against it. And as Dr. Avi had elucidated, that's what happened to us as well. And I totally agree with him. If you want to use it, you should use it early, because I think the only thing that will help you once you have the lethal triad and you have coagulopathy and everything else is God, whichever God you believe in. So it's quite difficult. I have my biases towards it. I think it could be used, but unfortunately nowadays I'm quite constrained and restrained from using it so much as we like to.
Right. Thank you so much. Another question for Dr. Avi here from one of our viewers is that, are you aware, Dr. Avi, that in Israel, do you use medical students who are not yet trained as doctors or who have not completed their graduation as some sort of a manpower in the mass casualty incidents, or you keep them isolated and would not use them?
No, we are not. We are using medical students in a daily basic activities in the emergency room.
Okay.
In So if they have the chance, so-called the chance, to be part of a terror activity or mass casualty event, they are there. We are training, and we are, I think, the only medical school in the world that train the students for 2 weeks. 2 weeks trauma. You know, they are eating, they are drinking, only trauma. And they are receiving lectures. They are receiving, we published it already in the Journal of Trauma. You are invited to look at it with all the schedule, what we are giving, what we are doing. You know, the editor wrote me a letter. He wants that we'll expand the limitation of word in order to explain the world what we are doing. So we are doing because of the Israeli situation, because of the so-called the peaceful country, we are teaching trauma for 2 weeks with a big drill in the end, big drill with everybody, with the EMS, with the police, with the Homeland Security, with the Air Force, with everybody. As Tina mentioned, it's money. However, and usually what we choose the place to do it, like in a train station, in the stadium, the soccer stadium, in the, you know, in places that the police wants that we will do it there, because they have all this information that they receive. The Homeland Security knows where are the sensitive regions in Jerusalem, and we are doing it. In the end, it's a one-day drill, and then there is we are sitting together with everybody, we are giving feedback, and the students are playing, you know, the smart patients. They are moulage, wonderful. They are really, it's an event in Jerusalem, and we are learning a lot. With all our experience, we are learning a lot. And the hospital is part of this drill, and of course of this education. It's really exception, 2 weeks, you know, to study and to learn. And they have an animal lab, and they're putting chest drain, and they're doing craniotomy. It's a really 2 weeks of trauma from here, trauma from here, trauma from here, and trauma from here.
Right. You bombard your students with trauma from everywhere. They can actually
don't have other choice. They are going,
yes.
Some of them are going later on to the army.
Yes, yes. Yes, I think all countries should take international best practices, and obviously it depends upon the condition in which the country is that they prepare for their resources. And because
I can show you, I will go back, I will see immediately the paper, but it's in the Journal of Trauma and Acute Care Surgery. If I remember, it's 2015, 16, but I will leave for a while, I will bring you the paper.
Thank you so much. And because we are discussing training, and Tina also, you know, sort of raised certain points about drills and training. So we have a question for her. Elaborate the triage drills which you do. Generally, how many clinician leaders would you expect to be trained? Because you raised a question of clinicians being trained in mass casualty incidents and being part of the not only the drill but also a part of the MCI plan. And should the roles be interchangeable? And can anyone be a leader based on the action cards? So this is one question for you.
That was not one question, that was 10 questions.
I can do them out one by one.
No, I think part of this is first of all, the leader involvement. I think the point is that there has to be a clinician involvement in leadership. So that means in the planning, because I think many places that has not been the case, and that makes the plan much less relevant. So the people who are actually, so it has to be someone So it has to be, and from different personnel groups, I think anesthesia and surgery and so on should be, depending on your healthcare system, should be the ones who know how to deal with it on the floor should also be part of the planning. So that's one thing. When we are doing the drills, and as I said, I think we believe not so much in the large scale exercises, because that gives false security. Most often those are very successful, and that means we don't have to do anything for the next year or so. At least in Social Democratic Norway, if healthcare, the government says that we need to have exercises, and that means we've filled our duty if we do one full-scale exercise, and that's it. And who got trained? One team. When it comes to the training, the smaller drills, what we see is that it's not necessarily exactly the few guys that are in the team being trained, but they spread the rumor. When they know a few days before that they will be part of an exercise, they go to their mass casualty plan and they talk to their colleagues. So these are residents often who are there in-house 24/7. They talk to their colleagues. I think that makes the others more prone to read their plan. When we do around the table training of them for triage only, then we can be 10, 15. We want to train our trauma team leaders who are the senior residents, surgical resident. We want to train them every half year. If we're achieving that, I'm not so sure, but that is our goal, basically, that they have to go through that drill and that discussion with us. And that is their main role in a session. Once it's decided to push the red button, they have the responsibility, and that's what they need to be trained for. Same thing with emergency department. I don't think they evacuate the emergency department every Friday, but they do quite often. They do this drill. Okay, we have someone pushes the red button, we need to evacuate the emergency department, and they do so. And I think all these bits and pieces that can be done often. The full scale exercises, they can't be done often. So you're actually not keeping the system on their toes.
True. Thank you, Dr. Tina, for that comprehensive reply, probably addressing all the parts of the question I posed to you. I would also like to bring in Dr. Karuna Dasa, because he comes from a country which was not very far away amidst a civil war, a civil conflict. And what have been your learnings in terms of manpower training and resource augmentation in Sri Lanka regarding trauma and regarding mass casualty incidents?
Yes, it is manifold. Now in our undergraduate curriculum, we of course has started to include at least 2 weeks of accident and emergency involvement, apart from their routine orthopedic and general surgical appointments. From a doctor's point of view, we do a lot of training courses through the College of Surgeons of Sri Lanka, targeting the medical population, not only for the doctors as well as for the nursing officers as well as the other healthcare workers. For the public, especially for the primordial as well as the primary prevention of trauma and the casualties. That is done by various collaboration with various other institutes like Ministry of Defense as well as Sri Lanka Medical Association and College of Surgeons associations like that. They have get together and arrange various plans for the public awareness. And the hospital training, of course, it goes under the purview of the Ministry of Health, which they regularly conduct hospital-based triage and drills depending on the available facility of each and every hospital. So we have a free healthcare system mostly all over the country, which is run by the government, and doctors everybody is paid by the government. So the system runs on its own without any trouble. So that is how we have prepared ourselves in Sri Lanka, because these incidents has happened regularly. So from preparedness point of view, Sri Lanka is, I think, bit always they are on the alert to face any calamity.
Right. Thank you, Dr. Nanda. Apart from the medical resource enhancement in terms of training, You very well, also spoke about training of the general public and how they respond to a particular incident. That's again very important. And that's where probably healthcare workers also come in, because they are taken seriously by the society. And if they say something and they give a message, I'll just give an example from our country, that I work in one of the premier institutions of the country in the capital. And I had the opportunity of being the media spokesperson and the media in charge of that institution for more than 5 years. And at that time, what I started was that I used to bring in batches of 10 or 12 media personnel, some health reporters, health beat reporters, or even editors or associate editors of major news channels, major periodicals and newspapers, and used to give them a overview of how trauma is taken care of at an everyday level, and what they should do as a responsible media person while covering a mass casualty incident. And I think speaker after speaker did mention about media role. And what positive I got from that was that when you tell them the problems which you face during mass casualties, and you have a workshop like that, they're also very interested in other cases, some interesting cases of trauma. And then your center gets a lot of media coverage, positive media coverage, instead of negative media coverage, which often happens with public sector hospitals. So that's a good way of managing media, calling them over and probably having workshops with them. So that was just, a errata from my side. Another question probably we have for Dr. Chong Sijak. Dr. Sijak, probably partly the question was also addressed by Dr. Laura, but many of the countries would not, especially in Asia, would not have adequate plastic surgeons or trained burn surgeons. So what do you think, how do non-burn centers prep up for burn patients, and how much should they know as general surgeons? So or which category of burns or which category of patients you think they can take care of?
What the ATLS protocol has managed or has been discussed is something quite well accepted in the burns community, that general surgeons with a basic understanding of wounds and debridement can probably handle less than 20% burns and simple skin grafting and coverage. I don't think that's a problem. When burns exceed 20%, the risk of SIRS, ARDS, and multi-organ failure and their infection drops. So it will be ideal for them for transfer to a regional burn center. So I think the cutoff line is probably 20%. And but in for example, especially in the US, the general surgeons are the ones managing the acute burns and the debridement. So if there's specialized training and all that, then I don't see that big a problem, particularly for the younger folks. So you could probably stretch it a little bit longer and then facilitate transfer. So in the end, I think it is about setting up a system. 20% and less, you do not need to transfer so early. For those in a mass casualty situation, then you got to triage and pick the patients. The three big parameters to look at is really age, body surface area, and the presence of inhalational injuries. And then you arrange your evacuation to the regional burn center based on the three parameters. A good guide will be the American Burns Association triage chart, and they have two separate one for normal situation and one for mass casualty. I thought those are simple guidelines for which is pretty well accepted in the general burns community for triage and evacuation. Over.
Thank you so much, Dr. Chong. And I think we are coming to an end of the open forum because of want of time. I'll just ask all my speakers and give them about 30 seconds to a minute to address the Asian audience and to give a brief 30-second overview of what they think probably could help the Asian countries or less developed countries in order to do anything regarding mass casualties. I'll begin with Dr. Paul Naes. So your message for the Asian countries on how to move forward.
I think nothing beats prevention. So you should actually focus very much on prevention, because if you can prevent one single injury, then that person will stay alive, and it costs actually nothing for the society. So prevention, prevention, prevention.
Thank you, Dr. Naes. Dr. Avi?
I totally agree with this statement of prevention. And another one that I would quote, if I can, Winston Churchill, never give up. Never give up, guys. It's once it happened, you should fight and you will win. Never, never give up. And as he showed.
Right. Thank you so much, Dr. Avi. Dr. Chong, any message from your side, sir?
Once you have the prevention and the fighting spirit, and then the last thing you need, I think, will be a planning. If you have a plan, then you can activate the resources. And if I'm very sure the medical community will come back on the weekends and overnights. So we've seen that before. Once you have a plan to activate them, they will come back and augment your teams. And I haven't seen a single medical professional turn down the call to duty. So I think you have a plan how to call them back, and then they will turn up. Over.
Thank you. And Dr. Tina.
I think maybe the most important message is you need a trauma system. And I think the basic, so there is, as I said, no excuse for not having a trauma system. So just because you have little resources doesn't mean that you cannot develop a system for what you're doing with the resources you have. And I think that has been a bad excuse. We have some experience with Ethiopia and trying to work with. There are lots of fantastic clinicians, and there are a lot of dedicated people. So the point is to work with your government and work with and like the work you've done, Amit, and others in India, to develop systems despite the limited resources. I think it's just great. And I just have to have one comment, and that was the comment to Novo 7. We were part of the randomized control trial. I think with the limited resources, that is going to be utopia to have Novo 7. But I think if we are, again, exactly the same principle of starting out early aggressively with whatever is available, cryoprecipitate and TXA, so assume that your patients are bleeding and start out by activating whatever they have coagulation. And I think that's also possible with limited resources.
Thank you so much to all the speakers. Once again, I must thank Dr. Raj Menon and Dr. Amila Ratnaike, who've been at the backside, but they've been helping us out tremendously for this open forum and for these webinars. Thanks once again to our chair, Dr. Professor Rolando, and to our scientific director, Chubing Turk. I'll close down this open session now, and let's probably have the final session of the webinar.